welcome everybody back to day 2, and welcome also to our online audience who are still there, hopefully, and paying attention. I've got the great pleasure today to introduce our keynote speaker. If you ever have a conversation about mHealth, you mention the word mHealth, it's less than a minute before you also hear the name Alain Labrique. The mHealth and Alain Labrique go hand in hand. He really is the world leader in mHealth, in research and innovation. Dr. Labrique is the founding director of the Johns Hopkins University Global mHealth Initiative. He is one of the top 11 mHealth innovators, according to the 2011 Rockefeller Foundation. He would be equally as comfortable giving this keynote address in Bangla or French or American. He manages to do all of this whilst teaching, whilst still leading massive research projects globally. And he is a mentor for anybody who is working or interested in mHealth. He's extremely generous with his time and his advice, and he's given a lot of advice to me in the preparation for this conference. So, like I say, we're honored to have you here, Alain, and welcome.
Thank you so much. Good morning, everyone. So I think I will do this talk in American because I'm on my way there, so I don't want to be too out of sorts. But it's really a pleasure to be here, and thank you, Ed, for the generous invitation, Tony, and His Excellency. It's great to have you here this morning as well. Yesterday was a phenomenal day. We covered a lot of ground. And mHealth, as you said so eloquently just a few minutes ago, is a burgeoning new field. I just tweeted something a few seconds ago that we are impatient optimists. The Gates Foundation has a blog which they publish on a weekly basis called Impatient Optimists, which emphasizes what many of us in global health really are. But when we think back to the genesis of the phone itself, we're talking about merely 100 and some years where we can actually make a phone call using a landline, let alone a wireless mobile phone. So I would say let's temper a bit our laments about the dearth of evidence, because we only have just entered into this mobile revolution. And the reality of connected populations is something that's only come about in the past half decade or so in many of the places where we in global health work. So it's really a pleasure to be here. And I'm going to cover some of the work that we've been doing in rural parts of South Asia, the collaborations we've had with groups like WHO, but also, I think, give you some of the insights that those of us working in the mHealth space seem to see the mHealth field heading into. And so as those of you in this audience who are students looking for dissertation topics or looking for ideas to innovate new solutions for global health problems, I would say there may be something in this talk for you to think about. So I trained as an infectious disease epidemiologist, and this is how we were taught to see the world. The countries of the globe here are inflated based on the proportionate mortality, infant and maternal, that they experience. And it's why I explained to my wife I spend most of my time in Bangladesh and India rather than in Baltimore shoveling snow with her, because that's where the problems are. But it's contingent upon all of us to try and find innovative solutions to address these grave issues that have been plaguing the global health community for decades, if not millennia. When we think about the magnitude of the problem, this is my touchstone image that I come back to every morning, reminding myself why I do the global health work that I do. Because despite the tremendous improvements that have been made in achieving the Millennium Development Goals, we are still seeing a Boeing 747 filled with new mothers and pregnant women crashing every 2 weeks around this globe. 10 countries on this earth account for 75% of this mortality. So when we talk about ways to accelerate progress towards MDGs, when we talk about the post-MDG research and innovation agenda, it's why we find ourselves looking at these information and communication technology opportunities to find ways to strengthen how frontline health workers perform their tasks, disconnected largely from the health systems that they serve. How do we get innovations in global health, strategies that have been demonstrated to be efficacious in reducing mortality. The things that Dr. Mel pointed out yesterday, that UNICEF and WHO publish tomes on ways in which to reduce neonatal mortality. How can we get those to these remote rural communities of the world so that they have the level of effective coverage to actually reduce mortality? When we talk about social barriers, a number of speakers yesterday mentioned the issues of gatekeepers, individuals who have the responsibility and sometimes are part of the obstacle of getting women to care in a timely fashion. How do we engage them in changing those decades-old paradigms of not seeking care in formal facilities? How do we engage them in participating in providing the levels of antenatal care and postnatal care that we know can avert the high levels of maternal and neonatal mortality that we see? Pregnancy in much of South Asia occurs in isolation. It's not the happy, joyful, communal event that many of us in the West might have experienced with our own children. Women are often secluded, isolated in the periods before childbirth and even after childbirth because of cultural paradigms of uncleanliness, pollution that go hand in hand with the delivery process. How do we, recognizing these deep-seated cultural paradigms, take advantage of some of these technologies to improve the outcomes that we've been seeing over and over in these communities? So I ask you all to join me in imagining a future across individuals, health workers, and health systems, where individuals have access to information, services, and the essential commodities that they need to experience healthy pregnancies and childbirths, along with the other aspects of health that go through their lifespans, where health workers have the skills, training, and support that they need to do their job consistently at a level of quality that is acceptable to those of us in global health. And then a health system that ultimately counts and is accountable for every life. Garrett and I, a couple of years ago, published an article in Reproductive Health Matters talking about how pregnancy registration in and of itself is an essential component of saving maternal lives. Because still to this day, in much of the world, we continue to estimate the number of maternal deaths that occur. Imagine if that were the case in the UK. If we were to say, we're not really sure how many women died in pregnancy because we just can't count them, we don't have the wherewithal nor the resources to do this adequately. There would be massive outrage at that statement. But yet this is the reality in much of the developing world where we work. Why are we gathered here today and yesterday? It's this reality. The fact that there are the same number of mobile phone connections on this planet as there are human beings on the earth. It's not something which the public health or global health community has purposefully invested in. And I let that sink in for a moment, because for those of you who are students of global health, think about what other paradigm do we have where the global health community has not invested in the infrastructure or the delivery channels for things like vaccines, for IMCI, for the other interventions of known efficacy, where we have had to create not just the innovation, but the entire delivery network to get that innovation to the communities which we serve. In the case of mobile, it's an opportunity that we have to take advantage of this ecosystem that has occurred without the investment of the global health community to allow us to optimize the delivery of care in these rural settings. So I call Facebook the tip of the ICT iceberg. 10 years ago, if you were to mention the word Facebook to someone in a village in rural Bangladesh, they would have looked at you with puzzlement and asked, what is this Facebook you speak of? Just last week, I was in Bangladesh, and I went to a village, and there was a 10, 12-year-old kid sitting there on the side of the banana tree playing with a phone. And I thought, oh, are you doing some kind of Java game on this phone? And he looked at me and said, no, I'm doing Facebook. I thought, Facebook? Who are your friends? No, the kids in the next village. These are my friends. I have hundreds of friends all across this entire district. And when you think about this is a map of the world without any political boundaries. And you can see how the entire globe is lit up. This is a map from 2011. Here's what it looks like in 2014. So if Facebook is the tip of the iceberg in terms of information communication technologies and social networks, imagine what's happening with mobile communications, just with the voice channels that many of us use. When we looked at our populations, where we've been doing community-based research now, working closely with colleagues here at UCL, Tony Costello being one of them, we've seen how mobile penetration has really transformed how people live their lives, not for health, but every aspect, from agriculture to market price checking. The ownership and availability of mobile technology has just been revolutionary in this context. We like to say we began our journey into mobile health by studying mHealth in the wild, to see how mobile was being used by individuals in the absence of any formal mHealth program. We studied near misses, women who said they nearly died during the course of pregnancy and childbirth, and we found that half of these women used mobile technologies from a range of purposes, to call providers, to arrange for transport, to ask for advice, but also to request financial aid. Because when you show up at an operating theater in rural Gaibandha in the north of Bangladesh for a C-section, the first thing that is done is you're handed a list that says, go and get catgut, suture, gauze, cotton, because the ER doesn't have those. You have to go and actually procure those and bring them into the operating room as part of your patient-borne expenses. So you can imagine that ability to mobilize financial aid using a device that's in the palm of your hand may be very transformational. But we sometimes suffer from what I would call boardroom problems. When you sit in a boardroom and you wonder, what is the mHealth innovation that we can apply to this particular context? And we rack our brains and say we couldn't possibly think about mobile technology in rural Gaibandha because there's no electricity. Only 23% of homes, in a recent survey we did of over 160,000 families, found that a quarter of homes had electricity. But almost 3/4 of these households had their own phone. So they've come up with creative ways of accessing electricity through small-scale solar panels, through battery exchange projects where they go into the market, buy their fish and rice, but also trade in their used battery for a new one based on a subscription fee. So the ecosystem has evolved to take advantage of these realities. We've also studied the growth in mobile penetration across all quartiles in a fairly homogeneous rural population. The take-home message here is that the top 2 quartiles of this population, the wealthiest of this rather poor homogeneous rural population in northern Bangladesh, were saturated with phones by roughly 2010. But what you see here is the lower base of the pyramid growing exponentially to meet those other 2 quartiles by 2013, 2014. So universal access to mobile telephony is a reality that we've actually documented in this representative rural population. And this brings us to the reality of mHealth that all of us have been talking about for the past day. And I would like to propose to you that we have, in this short space of the past 5-6 years of mHealth, actually seen 4 eras of this space. We've gone from an era of innovation and experimentation, and I promised I wouldn't use the P word, but my colleague did it justice already. But you know the word I'm talking about. It ends with itis and begins with someone who flies an airplane. That's the era that launched this field of mHealth. We then went into this era of discordant proliferation where everyone seemed to be investing in the space without talking to one another, without asking, what is it that you are doing that can influence my work, and how can we exchange ideas so that we're not reinventing the wheel? We now find ourselves in this 3rd and 4th era. Yesterday was a day of scrutiny and consolidation, thinking about what are the results of the work that each of you in the room who presented yesterday have been doing. And I'm really pleased. Over the past 2 weeks, I've had the opportunity to be with the Ministry of Health in Gujarat, with the Ministry of Health in Bangladesh, and having seen firsthand how they are taking the best of breed solutions that they have seen emerge out of this space and are beginning to integrate them. As we heard from His Excellency the Minister of Health of Ethiopia yesterday, integrating these strategies that work into mainstream enterprise-grade national systems. And I think that's where we hopefully are heading towards as an ecosystem. Over the past 5 years, we've come up with ways in which we can describe this ecosystem, the language of mHealth, as it were. And yesterday, some of you presented this work that we did a few years ago, talking about the building blocks of mHealth. And I think when you have a new field, it's critical that you share a common language. Otherwise, you end up talking past one another without that ability to cross-pollinate and actually understand the opportunities to work together as opposed to reinventing each other's work time and time again. It's also essential to realize, and this is something I tell my students who come into the mHealth coursework, is if there's one thing you learn is that there is no such thing as mHealth. mHealth is a diversity of applications of a technical strategy to solve a range of problems. It's absolutely critical that we, who are at the forefront of this burgeoning ecosystem, keep this in the front of our minds at all times. Because when you speak about an education campaign or a disease and outbreak tracking system versus a supply chain management or a health worker training mode, these are very, very different mHealth entities. They're measured in different ways, they have different indicators, and the markers of success and the benchmarks of evidence vary dramatically based on what is it that you are doing with the mobile technology. And I think that nuance in how we approach mHealth moves us past that conversation of, does mHealth work? Because then what is it that we're talking about needs to be clarified. We're also realizing that mHealth does not operate in a vacuum. The mobile innovation is part of a complex ecosystem of health system pieces that range from transportation to financial availability, training of health workers, availability of staff, when and where they're needed. And as we pointed out time and time again yesterday, one of the most impressive components of the Ethiopian system is the development of a cadre of workers who are trained to use the data. Because, ladies and gentlemen, we're creating an era of data like we've never seen before in a context that is still, I'll come back to that, that is still couched in paper-based mentalities. We need to train frontline health workers to be able to digest data and empower them with the ability to take decisions based on what that data says. That's the next frontier of where we take this mHealth innovation, not just creating better data, but creating systems by which we use that data to improve health system performance. We've also begun to codify these strategies into the complexity of health systems using frameworks that are well known to those outside of mHealth. Because if there's one thing that characterized the early years of mHealth, it was that we were all talking to each other, preaching to the converted. And what would happen is when we would go into the mainstream health systems or maternal health or child health world, we were sometimes seen as a bit of the lunatic fringe that, yes, it's very interesting what you're doing with phones, but have a seat while we talk about serious science for a minute. And we don't want that to be the reality. We want to bring the application of our robust scientific methodologies into this space, the application of known frameworks so that people can understand how the mHealth innovations which we're talking about can incrementally improve accountability of the baseline, supply, demand, quality, and cost. So we're speaking the same language as mainstream health system innovators. Garrett talked at length about the mHealth Technical Evidence Review Group, and a few of you have commented how WHO should carefully choose its acronyms, but unfortunately that was beyond our control. So MTURG it is, and that is with a G. So articulating mHealth strategies as a health systems innovation was among our first missions within that group. And so as we stratified mHealth as patient-centric, provider-centric, and health system-centric innovations, it helped us to really stratify what was happening in this ecosystem to be able to understand it better. So at the patient level, we're talking about information, demand creation systems, a lot of what the MAMA program and other projects have been doing around the world. Provider competency, the BBC Media Action's excellent work have really focused on improving the capacity of health workers to take better decisions at the point of care. Whereas health system adequacy improvements are really focusing on things like supply chain, staff performance, referral support, accountability, and reduction of counterfeits, as I'll show you in just a moment. The other important paradigm shift that I'd like to share with you, and was also shared briefly yesterday, but is this concept of mHealth as a way of taking interventions of known efficacy to reach effective coverage. Because we have already with us a litany of strategies that we know to be efficacious, whether those be vaccines or essential newborn care strategies that Anthony Costello and Ed Futrell and others in this room have really pioneered and pushed out there as ways to prevent and reduce neonatal mortality. But we run into these potholes in our struggle to reach effective coverage. And these are just three of many of these potholes that pave the ground between us knowing what to do and doing it at scale. So mHealth is really a way to fill those potholes, whether incrementally or completely, in order to reach that end goal. So the question I propose to you is that we no longer ask, does mHealth work? But does mHealth optimize that which we know works? And I think that nuance will also shift the way in which we measure and design our evaluation schema around the mHealth space. For those of you who are into structural geekishness, taxonomies is something that you know and love very well, and Linnaeus started off a pretty obsessive-compulsive movement to go through the world and label everything with much detail and clarity, and this is what we tried to do in the mHealth space. We created an exhaustive taxonomy. It took us 1.5 years of consensus building across the mHealth ecosystem, getting people to describe what it is they were doing in a consistent language. And this taxonomy is available online, and we've now used it to go into great detail so that your project can be described in a way that it can be compared to what you're doing in that ecosystem, to understand where there is overlap and where there is potential for interaction. One of the bins of this taxonomy that I really enjoy looking at is the constraints bin, and that is really an amalgam of constraints frameworks that the WHO has created over the years, but it focuses us not on the technology, but on the problem that we're trying to solve. And I think this is absolutely critical as we think about moving forward in this space. For those of you who are just beginning your journey into this mHealth domain, think about first, what is the health system constraint or constraints that is plaguing your effort to reach effective coverage with that intervention of known efficacy, and then go through and figure out in that logic framework which of these constraints and how your mHealth innovation is overcoming these problems. We've also used methods like the LIST tool. It was a tool developed with the Gates Foundation and researchers at Johns Hopkins to model the impact of improving coverage of interventions of known efficacy. So if you can measure the extent to which your mHealth solution has extended coverage, you can now expand that using robust modeling approaches to determine how many lives you may save by that improvement. We've done modeling in this paper for Uganda and Bangladesh to identify strategies that might provide the biggest bang for the proverbial buck that one might invest in the mHealth space, looking to improve coverage of a certain intervention, whether that be skilled birth attendant or optimizing immediate breastfeeding shortly after birth. It's also a tool for governments, where as governments consider which of the mHealth solutions lining up outside the door they should be investing in, looking at the potential impact of improving one area of a health system versus another might be a valuable approach to determining where they should invest their monies. But let's take a quick look at how, in addition to the great work that we saw yesterday, mHealth is being used around the globe. First, let's start with the client. Many of you are familiar with MAMA. This is a project that began inspired by programs that were being done in the US, providing targeted text messages to pregnant women which were gestationally aged appropriate. So at each stage, at each week of pregnancy, a woman would get a voice or text message about behaviors and actions to take during their gestation. This program has last year, as of November of 2014, formally been adopted by the Ministry of Health of South Africa, not just as a public good so that all pregnant women receive these messages, and as we said yesterday, this is in the dearth, with a dearth of any sort of robust evidence of impact, this adoption has occurred, but also as a way of registering pregnant women during the course of routine surveillance by community health workers. So now this is a national program, and it's being scaled up in India as well as of January of this year. There are systems, and this is, as our colleague from the London School pointed out yesterday, Carolyn Free, that this is one of the domains where we have, I think, a robust body of evidence that mHealth can have a substantial impact, and that is improving adherence to complex drug regimens. So whether those are AZT or antimalarials, providing those daily reminders to those of us who are typically forgetful of taking our medication. I know I'm a very poor patient, and I would challenge anyone in the room who's been on a complex drug regimen to say that they took every pill whenever they were supposed to during the entire 7 or 14-week course. As human beings, we're fallible, and we tend to forget when it is we need to take our medication. And so there have now been numerous RCTs that have shown providing that text message reminder can be transformational. We heard a lot about Mobile Kunji yesterday, and the Mobile Academy that Ananya and BBC Media Action have been doing in Bihar. And I think this is a phenomenal way of empowering the health worker to be more self-efficacious about her knowledge and actions in the community, but using that mobile tool to standardize the quality of work that these workers do. UNICEF now, for almost a decade, has been using simple structured text messages to allow frontline health workers to send the messages about the mid-upper arm circumference to track nutritional growth of young children as a way of identifying kids who may be experiencing growth faltering in rural communities of East Africa. We've seen innovations that leverage the camera. Our colleagues at Stanford University have developed an attachment to the camera that allows you to scan the inner buccal surface and take pictures to identify and task shift the job of screening potential precancerous lesions in the mouth as a way of accounting for the low numbers of clinicians who are available in these communities in India to actually perform that screening where it needs to occur in the villages. We've seen from our own work in Bangladesh that these kinds of integrated solutions, starting with basic enumeration of a population, pregnancy surveillance, integrating antenatal reminder, but then empowering the clients, the pregnant women and their families, to send a notification when they're having labor pain or have experienced a birth, has now been, we're in the process of analyzing this data, but the results have been unexpected. We've seen a 3-fold increase in antenatal care utilization in rural Bangladesh, attributable to a single series of messages sent to pregnant women during their pregnancy, 5 days before their ANC visit date, and on the day of their ANC visit date. And postnatal care went up about 2-fold, also using that same schema of reminders to clients. But we also have new frontiers emerging. We're seeing the emergence of mobile microscopy. Our colleagues at UCLA have developed a whole slew of really sophisticated but easy to use mobile microscopes that I can imagine coming to bear very soon, We even have used this technology, Sonosite, in a project in northern Bangladesh to do ultrasounds looking for malpresentation in pregnant women in rural communities. So these are off-the-shelf, FDA-approved technologies that any one of you who is a provider can go and order and use in your research and field work. At the systems level, Garrett presented the results of work done by a number of groups, but in this case, Novartis and the Rollback Malaria Program have done this project called SMS for Life, where they ask frontline pharmacists to send a structured text message informing the pharmacy stock supply, central supply, when the stocks of a particular drug are diminishing. And what that allows the central supply to do is replenish those stocks before they run out. And although the evidence is still weak, where these systems have been used, the results have been fairly dramatic, going from 70 or 65% stock out rates to less than 10 and sometimes even 0 sustained stock out rates in these communities. But the need to continue to demonstrate and evaluate these rigorously is certainly important. In Ghana, and Nigeria, where drug falsification is extremely prevalent, groups like Sproxel have come up with scratch-off codes on the back of their blister packs to be able to enable clients to text message in that blister pack code in order to understand whether that is an authentic drug or whether it is a forgery. And so another innovation that empowers the client to verify whether the system that they're being a part of is genuine. But simple things like the turnaround time between the taking of a blood specimen and determining whether that individual is HIV positive. In Project WANA, they've published the results of almost a 46% reduction in the number of days it takes to get that result back to the patient in order to initiate treatment. So fairly impressive data coming from these kinds of very simple process innovations. So I think as we consider what are the areas where those of us who are researchers in the room, as we consider what is it that we're trying to demonstrate the evidence of, I think across layers of patient, provider, and health system, there are certainly some hypotheses that we should be testing. Because these, I believe, are the low-hanging fruit that when MTurg sits and looks at where are the research priorities for the next few years, they certainly seem to be suggesting improved client access to information, improving methods of counseling in BCC, bolstering client adherence to medication, reduce turnaround time and improve workforce scheduling, and then strengthening supply chains and creating shorter feedback loops across the health system for prior response. So what have we learned? Because 5 years is not a long time as we think about the maturity of this ecosystem. And I think we've made mistakes and we've made missteps, which we're trying to learn from as opposed to continue to make. I would say one is that rigorous evaluation and evidence generation, as we've all been calling for yesterday, can coexist with innovative experimentation. I used to, but I no longer advocate the death of pilots because I think they do serve a critical function in this space. We also know that the donor mechanisms that fund new innovations in mHealth are actually geared to support pilots and not scaled innovation. And until that changes, we will continue to see a proliferation of seed ideas, let's call them. When you look into the brain of an engineer, and my apologies to you, sir, because this is what I think we would see. Because when we talk about our strategies of how do we develop innovations, I remember many a meeting with my engineer colleagues at the Global mHealth Initiative, and I'm talking about trials, and Tony knows very well what I'm talking about when I say a trial. And the engineers in the room looked at me and says, yes, of course we will do trials. We will do 50 trials. At which I step back and I say, goodness gracious, it took 10 years for us to do one trial. How are you going to do 50? Because the trials they speak of are these spiral of development trials where there's an iteration of prototype, rapid feedback, re-engineering, re-prototyping, re-rapid feedback. But what I present to you, ladies and gentlemen, is that this process needs to coexist with the rigorous RCT process that those of us who are in public health espouse. And that's because mHealth really is a marriage of these two disciplines, engineering and public health. We need to do both the robust iterative development as well as the rigorous evaluation in order for that end product to hold water when it goes to enterprise level. The challenge, as many of us were discussing in one of the breaks yesterday, is that the funding for this level of innovation is often lacking. And we've spent several years for mCare, for another vaccine program, doing this only to find ourselves with a paltry amount of funding left in the bank when the time came to actually do the robust evaluation. So donors tend not to be amused when you go to them and say, I don't have enough money left to do the thing that you wanted us to do. Improvements in archaic institutional process could translate into health impacts. When we think about Sri Lanka, India, Bangladesh, Pakistan, Nepal, all of these countries, and with due deference and respect to the empire, this is a legacy that the British Empire has established. The culture of data collection that unfortunately ends up looking like this, that's inaccessible and unusable for the health system. And in fact, we just did an analysis of the Bangladesh frontline health workers. They use 19 ledgers for one cadre of frontline health workers, the family welfare assistants. 473 fields could be reduced to only 60. So I tell my American colleagues, that means they spend one day each week of their lives doing their tax returns, where you move the field from page 1 to page 4, add up column B and column C, and the tremendous amount of time that's lost in doing these 473 fields is just untenable, because that time could otherwise be used in providing care and services to these workers. That's why with WHO and UNICEF, we've been working hard with a consortium with Harvard and Hopkins to build what we call the Open Smart Registries platform. Like we have an open medical record system called OpenMRS, this platform aims to digitize, using strong user-centered design principles, digital registers that can reduce that burden of aggregation and paper-based data collection into workflows that are horizontal, similar to the paper-based systems that those frontline health workers have long learned to use. We noticed in those paper systems that workers use different colored pens to mark their clients for prioritization. And so those kinds of lessons have been integrated into the user interface that characterizes Open Smart Registries. That's going to be launched on February 8th in a meeting in Bangladesh just in the next week. What's also exciting is that because of the digital nature of this platform, we can now also provide multimedia content on demand. Imagine, as you're going through a decision support algorithm, checking whether a woman has anemia, finding low hemoglobin, and that prompts a video to come up that the health worker and the client can then watch together, that is presented when and where it's most appropriate. We must also harness digital for research as well as intervention. So many of us talked about yesterday this dual reality of being able to use digital to collect data. And I think that's another fundamental opportunity that we have, to be faster, have fewer errors in our data, and potentially do this for cheaper. So Peter and I, we have an unfinished argument to have later on over coffee about whether there is in fact enough evidence that paper methods for data collection can sometimes provide us these benefits. We must also close the data loop. And for those of you who are behavioral scientists or looking at incentive schemes, I think this is another exciting new frontier for research. Figuring out how to provide incentives to those health workers based on the quality of work that they've done, based on feedback from the client. Imagine after a community health worker goes to that client, being able to get feedback from the person who's received an antenatal care session on whether that care was satisfactory, respectful, adequate, answered her questions with sufficient depth. We talked a little bit earlier about building a culture of data, and I'm not going to go into much depth about this, but this is self-evident, that as we create more data streams, we need to not just create the capacity among the health workforce to deconstruct this data, but also empower them through policies and through permissions to take action. Imagine if I was a pharmacist 2 kilometers away from you, and I knew that I had an impending stock out, but instead of being able to use some of your stock to tide me over for this week, I had to put a requisition to central ministry to get my stock levels replenished that might take up to 4 or 5 weeks. That simple transaction needs to be a policy level decision to enable systems to be more efficient. So we can't go, ladies and gentlemen, from this reality, which many of you know to be true, to this reality. And, you know, as our good friend here seems to be quite frustrated, I think I'll put some words in her mouth that more data is not better information. And I think those of us who are data scientists in the room need to understand how to better visualize complex data so that it makes sense intuitively to those frontline workers who are dealing with this work. We must leverage the reality of a connected population. UNICEF has done some very innovative work with work like U-Report, providing citizens who have phones to give feedback to the ministries about the performance of their health system at the local level. So submitting complaints about corruption, submitting complaints about poor performance, which then can be acted on by the central ministry level. We've enabled pregnant women to send us notification about labor, as I mentioned earlier, which we thought from an anthropologic point of view would never work. Because there's been ample work done that shows women conceal pregnancy in these rural communities. 500 pregnancies later, 90% of women involved in this study sent us a text message saying they were going to labor, because they knew they would have skilled nurse midwives dispatched to the home to provide care in this rural Bangladeshi community. We have to learn from M failures and not repeat them. We were heard yesterday about the M registry, and I encourage all of you who are doing global mHealth work to please visit this site, go through the short questionnaires. You will be given a unique ID number that you can use in your publications referencing the M registry. But this allows governments, donors, and innovators to look for common innovations in the space of M registry. WHO is also developing the MAPS tool, which is mHealth assessment and planning for scale, as we've gone through a very, very rigorous process of figuring out what are the essential elements required in order for a project to build for scale, as we've all been talking about over the past few days. Building a pilot is not the same as building for scale, and you have to be thinking about these various axes of foundational support that allows you to have a robust enough architecture to scale your mHealth solution. The PMNCH, the Partnership for Maternal and Newborn Child Health, has just released a toolkit that allows you not to assess the project's ability to scale, but the country's readiness to scale a program based on existing policies, existing human resources, and 7 other axes that look at country readiness. So I also encourage you to go to the PMNCH website and take a close look at this tool. As I said before, I think we also need to inspire ourselves by how mHealth is being used in the wild. And let me just ask you, who can say what this thing is? Let me just see a hand in the audience. Yeah, it's not a SIM card. Okay, it's a micro SD card, 32 to 64 gigabytes. That's about 600 full-length movies can be stored on this micro SIM. And across rural Bangladesh, this is what it's being used for. Women are buying micro SD cards for less than £1 to watch Bollywood cinema. Imagine if we could preload a micro SD card with health content and make that available to communities across the globe. This card costs less than 50p. The private sector is not waiting, ladies and gentlemen. In India, in Bangladesh, doctor hotlines have emerged, allowing folks to get advice and enter into a long relationship with a virtual health system. IMS Health and others are developing app libraries for prescription strength applications. I gave one of our colleagues in the audience one of these yesterday to play with. It's an FDA-approved 2-lead EKG, and you can now buy this off the shelf, take your EKG, and send it to a cardiologist here in England for £5, get an assessment of your cardiac health. Now, I don't know what the clinical utility of that might be, but there's a lot of new data coming out that you can detect arrhythmias and potentially improve diagnostics at the point of care. I would encourage everyone to contribute to this ecosystem because mHealth is uniquely collaborative, but also keep in mind that it's not just mHealth that's taken off in the past 5 years. The things like mHealth evidence allow us a window into a rich world of not just published, but also gray literature that we can stand to learn a lot from. And I think what you will see is the world of mobile money interspersed with mobile health offers a massive opportunity for instant remuneration, conditional cash transfers, and incentivizing frontline health workers. But also looking at things like mobile agriculture, allowing farmers to not only understand improvements in their crop dynamics, but how does that feed into providing healthy nutrition for their families and their communities. Building for scale is not simple, and I just want to emphasize this once again. Most pilots were never built to scale. So before we lament the fact that they haven't scaled and we've seen so many pilots, I encourage you to think really hard about whether the funding that those pilots received actually were built to scale. There are very good guidelines, and this is a resource that many of us are signatories to, known as the Principles for Digital Development that is here at ICD4D Principles, that really talks about what does it take to create an enterprise-grade national health, mHealth solution. And yesterday when His Excellency was presenting the work in Ethiopia, many of these principles, including the use of open standards and open source, were espoused as part of the Ethiopian mission. I think the role of government, as was mentioned yesterday, is a critical point. And I underlie our colleague from BBC Media Action summary this morning that government provides that backbone for collaboration at a national level. So we don't see the kind of moratorium that happened in Uganda once again. Government sets policy. They set the build to standards for mHealth innovators to be designing their solutions aligned with the other innovators in the country. Defining priority areas so you don't have innovators going off and inventing solutions that don't have applicability to that country context. Providing a forum for collaboration, mapping the ecosystem, but also incentivizing the private sector to get involved in this innovation space, I think is a challenge for all of us in the mHealth space. Nigeria is undertaking this at a national level, starting with policy all the way to implementation. And Bangladesh, a country where I've had the privilege of working now for 26 years, it's really been a phenomenal leader in thinking through national level architecture, hospital level e-health architecture, all the way down to frontline health worker support. They just purchased 45,000 tablets for their frontline health workforce. So we have to ask ourselves, what is going to be on those tablets, and how do we leverage that opportunity to improve health for all? As some have said, with all of this wizardry and wonderfulness, let's not forget the power of the phone as a phone, because I think the capacity of each of us to talk to one another still remains a powerful human interaction. And whether it's to a call center or to another health worker, I think there's a lot of potential there for us to think about. The world is increasingly connected, and the level of transparency that we as researchers and innovators are subjected to is greater than ever before. But I encourage us also to work together, and I'm thrilled that Ed and others put this meeting together because it crosses that transcontinental divide that really was artificial, and we need to move forward over the next few years, working hand in hand. So with that, I thank all of you, and I look forward to the rest of the day's deliberations. Thank you.
Thank you so much, Alain. That was fantastic, as expected. Please don't leave.
No.
Take a seat. We have got about 20 minutes for questions and discussion with Alain. And after a huge, comprehensive, I think, summary of the evolution of mHealth.
We'll rehydrate.
A little rehydration. Think of questions.
Hamish Fraser, University of Leeds. Great talk, Alain, as always. Great to see you.
Hamish is an old partner in crime, so it's great to see you out there.
So one of the themes that came up yesterday, I think Dr. Free brought up, was the question of how well the intervention is described, as well as how an evaluation study is described. And I think you really alluded to that quite well in your talk as well. So we've gone from a situation from the famous BMJ paper on the descriptive feast and the evaluative famine, possibly to a situation where we're just focusing on the evaluation, but that critical stage of developing and improving and scaling the intervention needs to be described somewhere as well. So I think there's a tension about how we do this, and I believe we saw this particularly with the eHealth and mHealth response to Ebola, where there's not a lot of information about what everybody's doing, even though we know it's important. And I think there's this lack of understanding about how the systems are being developed and scaled makes it harder for us to actually interpret the evaluation data. So I wonder if you had any thoughts about the best way to address that.
So it's a great question. Yesterday, our colleague from BMJ actually put out a clarion call for all of us to publish our protocols. And I think there is actually a step prior to that, that is publishing our processes of development and the actual qualitative research, the formative phase that most of these innovations undergo need also to be published. Because one of the challenges, and we're in the midst of a heated argument with one of our collaborators in an mHealth project who has just put together a manuscript saying that there is not enough space in the word count to adequately describe the technology, let alone the formative research that went into building that technology. So the solution is either to publish in a journal that has no word limits and then hope someone reads the 12,000 word paper that you publish, or to divide that into a series of publications about the formative work, the protocol of the actual innovation evaluation, and then the results of that study as well. But I agree with you completely. It's absolutely critical that we get those out there. The Ebola issue is something that we at Hopkins were also part of this consortium, and we realized that there was this chaotic response with many groups developing ICT responses to Ebola. And so one of the things that Merrick Schaefer at USAID, working with his colleagues at UNICEF, began to put together an online list saying, if you're doing something in the Ebola response, please document it here. And fairly soon, we had a list of over 139 groups and individuals actively creating ICT responses to the Ebola outbreak, some of which were coordinated and others which were not. And as you can imagine, the PR value of putting something on your website saying, we're designing the solution for the Ebola outbreak is a very powerful thing to say, but I think it also leads to this frustration on the part of the ministry, the local Ministry of Health, saying, you guys are such a mess. Don't bring your mess into an already chaotic public health crisis. Figure it out and then come to us with a concerted solution. So I think WHO in that instance actually took substantial leadership, bringing together a core consortium and saying, let's put together some standards, let's settle on a couple of platforms, and let's move forward with these as sort of the mainstream country level platform. So I think we have a lot to learn from what happened in the Ebola crisis.
Thank you.
Please. Dr. Patel. No, I haven't seated all these people in there to ask me.
Alain, thanks for that. Great talk there. You obviously described an evolution there in terms of data collection, point of care, the way we now implement programs, and so forth. But as a clinician who works in tropical med and also at mHealth, probably call myself an mHealth practitioner, up to last year, we had maybe an umbrella group such as the mHealth Alliance that provided some sort of governance that wasn't legally binding as such. What do you see as, throughout all this process, through all these years of mHealth practice, we still have nothing that we are legally obliged to practice with? In other words, there are no guidelines set. We have frameworks that are published, but as a practitioner, I'm not legally bound to practice to that, I'm not legally bound to set a study a certain way. And I know we're going to be talking about ethics later on today, but that obviously comes into play. So what do we do next? I mean, because as a practitioner, I'm obviously obliged to practice according to the CDC or according to the Royal College, but what does an mHealth practitioner do?
So, thanks, that's an interesting question. I think what I would do is deconstruct your question into a question about global mHealth guidance and guidance for mHealth in the developed world for clinicians. And I think those are fairly distinct spaces at the moment, because in one instance we're talking about public health interventions that are at the population level, and at the other we're talking about interactions between patients and providers in a very clinical setting. Let me address the high-income clinical setting first. And there we have a tension between the health applications world, so the health apps world that's proliferating much more rapidly than any of us can keep tabs on. 67,000 apps in the App Store related to health, hundreds of thousands in the Google Play Store. So consumers are downloading these applications for their own self-efficacy and perceived benefit. Wearable technologies such as Fitbits, I have one in my pocket, but I've actually gained a few pounds since I bought one, so my wife tells me I'm not using it right. But the FDA has just come out with guidelines saying that they have relinquished oversight over these kinds of consumer self-efficacy apps, as long as the claims made by those devices and applications are not curative, but they're just preventive, so to encourage healthy lifestyles and so on. So we will continue to see consumers purchase and use these devices, and as the clinician, the challenge is, do we or do we not put any value into the data that those devices and those applications generate? So if a patient comes in with a food diary that she's collected on an application, do you as a clinician review that just as you would have done another sort of clinical tool? Would you trust this series of weekly ECGs that were taken by a patient in their home using this AliveCore device? And that's something that there isn't very much guidance to do. But from a provider side, I think one of the challenges that we've been talking about is the need for an entirely new paradigm of prescription strength apps. And what that means is, just in the way that you would write a script for a specific antibiotic or a specific application ointment, you might also be thinking about in the near future writing a script for this particular application that has gone through a very rigorous process of examination and certification, that it can provide consistent, high quality, reliable, dependable service to that patient in order to remind them to take their medication, but also take their weight, and it's automatically entered into that system. So I think we're on the verge of that kind of a reality in the near future. For global health, for global mHealth oversight, I think the dissolution of the mHealth Alliance is an interesting problem area. And it comes also with the creation of mHealth expert groups within every professional entity, every professional health entity that I know of in the US, going from the American Pediatric Association to the American Cardiology Association. Every group now has an mHealth working group within it. And what that means is that mHealth has now undergone this decentralization, eventually leading to that point where we won't be talking about mHealth anymore. We'll be talking about these digital strategies that are embedded within the practice of cardiology, the practice of pediatrics. And I think that's sort of where we're leading in terms of this sort of decentralization. From an ethical perspective, I'm sure we'll wrestle with this later today, but IRBs, as we heard from our colleague from BBC Media Action, are struggling with how do we protect patients' confidentiality and ownership of data in a digital era. And as those of us who are trialists have been doing paper-based trials for decades now, we know that we have to be extremely careful about the management of those paper records. That same level of compulsive monitoring of the confidentiality of information that's on the paper record has to accompany the way we treat digital health information as well, irrespective of whether this is in rural Uganda or Bangladesh or here in the UK. Patients deserve the right to protection and safety of their data, and I'll also mention permissions as to who can see that data in its granular form, because I've had many a conversation with governments where there's a position that says, I'm the Ministry of Health, I have the opportunity, I have the right to see granular data, when there may be provisions within that health system that say, unless you're in the direct chain of treatment for that patient, the only data you have access to is de-identified granular aggregate data. So I think we have to think through those as well.
Great. I love the idea that the success of mHealth, in some areas at least, comes through the dropping of the M, and it just becomes health, and it is just the way that health is done.
I mean, I think last night we were talking, Sophia and I were talking about why do we have these meetings? Because if we were to come back here in 2 decades, we would see that many of these things that are presented as cutting-edge innovation are so mainstream we don't even talk about them anymore because they've just been absorbed. I think part of why we gather together in these meetings is to accelerate that process because of the aircraft that I shared with you earlier. It's untenable that that rate of mortality continues to persist. So if we can accelerate our reaching that endpoint, then I think it behooves us to do so.
Excellent. And then we have a question from Jeff.
I was very interested in your reference to the List Life Saves tool. Made me think that in evaluative and appraisal work I've been involved in outside the mHealth area, it made as much use of modelling tools as of control trials. And I wondered what you thought of the more general use of modelling in evaluative work in mHealth.
So I think part of the interest in using a tool like List stems from the earlier principle that we were talking about of using mHealth as a means of modifying the level of coverage, where it's really a health system strategy to optimize the delivery of a particular intervention whose efficacy is known. So in that instance, I think doing the RCT with an outcome that is not, how many measles cases have been averted by the vaccine, but really to what extent we've improved coverage in the intervention arm versus the control arm, shortens the time of the intervention. It possibly reduces the sample size and consequently the cost as well. So I think the same methodology should be applied, but ultimately the question comes back to what is the health outcome? And this modeling tool is one that has been extensively validated to demonstrate that the results of the model do actually match up with observed reductions in mortality once a certain scale of coverage has been reached. So when you're using a validated modeling approach to measure that health outcome, I think it's perfectly reasonable to assume that the change in coverage that you've measured using a robust methodology should be accompanied by that resulting mortality impact as well. It's just doing the mortality study would likely cost an order of magnitude more and take several years longer to finish. So impatient optimists that we are, we want to get things moving.
We have time for just one more question, I'm afraid, but Alain is staying around afterwards.
Yeah, I'm
happy
hostage
to talk about mHealth
till past lunch. So I think you had your hand up.
Jean-Christophe.
Christophe.
Thanks, Alain, for very good presentation. I very much like the 4 areas of mHealth that you described, and good to hear that you are now moving from stage 3, from area 3, which is scrutiny and consolidation, to integration and scale. So I would like to hear from you, from your experience, what do you think is the readiness of the mHealth project implementers to really ask the right question, make the right assessment in order to make meaningful improvement in the health system? Are they ready? And as you said earlier, most of these projects, this pilot started with no intention whatsoever to scale. But these are the same actors now who need to come together, make the right assessment, and then propose how to integrate into a holistic system.
It's a great question, Jean-Claude. One of the tragedies of pilots is when we fail to actually learn something from them. And I think that's why many people complain about the proliferation of these pilots without necessarily a scrutiny as to what was it that we learned from this small scale operation that wasn't made to scale. Is there some nugget of wisdom that we can take from that experience and apply it as we build something more robust? As we look at some of these programs, and unfortunately there's not a plethora of donors in the room, so I can feel fairly, if you're a donor, I apologize to you in advance, but and we'll have a chat about funding. But I think donors themselves have been a bit trepidatious about how much they invest in this emergent space. And so the investments have been very small, leading to these sort of poorly designed, experimentally poorly designed studies that don't have all of this architecture that allows it to scale. But then when initial successes are seen, the donor comes back and says, well, that seems awfully promising. Can we now take it to the entire district or take it to the entire state or country? And as an innovator and as a starving academic, a big check is very hard to pass up. And so we tend to say, sure, we can scale it. Just give us some time and we'll do some re-engineering. But it's not as easy as that, because what we're finding in our own work is we often have to dismantle the entire code, take apart the entire system that we've built and recreate something a lot more robust with the same features, but now built for scale. And we have to explain to the donor that we need those additional costs because the first time around we just hadn't built a Mercedes, we built a go-kart. And so now we need to really build this for national scale, and that's going to take a lot more robust coding. In the case of the smart registries platform that we talked about, there are 4 countries involved in this process: Indonesia, Bangladesh, Pakistan, and India, all of whom had at the outset a similar product, but not quite that robust OpenMRS grade platform. And so each of us is going back to the drawing board, taking several steps back, deconstructing what it is we learned, putting those into the specifications as we build something now that is enterprise grade mHealth. And so you have to be willing to look with great scrutiny at what it is you've built and understand that toothpicks are not going to hold up a national health system. And so I think it's that willingness to have that difficult conversation with the donor that we need to figure out how to do.
Fantastic. Unfortunately, we are out of time for this dialogue. So just leave to say thanks very much again.
Thank all of you. It's a great morning.